Our graft quality has improved, which we talked about. Our operative time has decreased significantly. I can now do we just did a 10 centimeter labral reconstruction with a ton of bony work on the ball and the cup in 3 hours. Now, we're not rushing, we're just efficient. We know our steps, we know when to start making the graft. Chris Irons, who makes the grafts for me, does a beautiful job. So we've got a nice streamlined system in the OR. We don't mess around. We have a fun time, but we don't mess around there. So it's nice and efficient. We don't have any donor site issues. Now, the other cool part about this is if you look at the blue arrows, that was my original reconstruction section. Okay? So I used to put a little anchor down here in the front because it was as low as I could go. You have to remember in the cup, it's not like you're staring in at this cup. You're working around the ball. You're working through a centimeter of space. It's pretty tight. So to get down this low is very hard to do. But the advantage, again, this goes back to my philosophy of the hoop fibers all the way around. If you disrupt from here to here, this is going to come loose with time, even if you have a suture around it. Because, again, remember, everything in orthopedics, a fracture, a sutured piece of tissue, anything, it will fatigue fail with time if it doesn't heal. And so this sees a tremendous amount of stress. So what I've done now, is I've taken the graft all the way down to the bottom, down to the origin of the anterior transverse acetabular ligament, and I take it all the way back. Sometimes I've taken it all the way down to the bottom to reconstruct it as well. We've done a couple of total reconstructions. It all depends on the quality of the tissue back here. The nice thing is we work primarily in flexion, so we can get away with leaving some of the posterior labrum because we don't really work in extension that much, and that's worked very well for us. The key for this, the advantage of this, is we're not leaving any bad labrum on the bottom. So it is absolutely very, very rare for you to see a labral reconstruction that gets catching down the line. Now, this, we made a video, and I'm going to try and narrate it. I owe a lot to Andrea because she edited this. So it's got a cheesy introduction here, but it's, at least you know what's going on. So when you see here, this is a patient that we did a hip scope on. And now look at this labrum. It's stringy, it's nasty, it's red, inflamed. This is one that I get worried about. If you repair, you're going to have a problem with it down the line. It's going to be sore and painful. This is after we remove the labrum and burr back the cartilage in the rim. You can see we're all the way down to the origin and transverse acetabular ligament. Nice, clean cup, beautiful cartilage on the ball. Functioning, all arthritis gone. Now we drill in one of the 6 anchors. This is basically, it's just like a molly bolt, except it has a suture built into it with an eyelet. And so we press that in. I use a material called PEEK. We use Linvatec anchors now. And one Smith & Nephew anchor, and that basically is a plastic that's bio-inert, so the body's not going to react to it, because the key with your anchor placement, you have to have it on the rim, right next to the cartilage. If you don't, you're not going to get your graft where you want it, because the graft's going to go home. So that's why we put all of the anchors in first. So you can see all 6 of these anchors coming around, all nicely spaced, and right on the rim. If you have something that's bioabsorbable, you're going to have a problem with it. Now what we've done is we've fixed the first suture to the graft, and we just push the graft in. Okay, so this is all done arthroscopically through 3 incisions. We now have it laid out. This is the cool part. So you can see we're using the pulley to kind of cinch it down. So now it's cinched down in the very bottom with a suture that's fixed through the graft, and then we just progressively fix it from front to back, keeping appropriate tension on it as we work our way around. And so this is just tying one of the sutures down. But you can see, good looking graft, again about 5 to 6 millimeters in diameter. A really healthy tissue. Allosaurus and MTF have been providing us with, fortunately and unfortunately, really young donors. And so the quality of tissue, because we're the only ones kind of using this tissue right now, is excellent. And so hopefully we're establishing a VIP status so that this quality graft is always available to us. I'm really petitioning for that because I think it really makes a big difference. So now in the back, the benefit from working the front to back is that you can now cut excess away. And so if you fix front, then back, then fix in between, if your length isn't perfect, then sometimes you can have some bagginess to it. So this allows us to get the graft perfect. You can see it goes now all the way down to the end. This is an instrument that's designed to push the suture through the graft so that now on the end we basically have a suture that's going to go through and around, and that prevents it from being able to slip out. So the graft can't slip out of our hold. But this is a really, really cool instrument. I've been happy with this. So now we're going to wrap it around. And then when you pull on the other suture, you can see that it'll pull it down in place. And it's probably about 2.5 hours of work, of boning work, or 2 hours to get everything clean like this. And the graft probably takes about 30 to 45 minutes, depending on how tight the space is to work in. This is a really generous space. This is why it became a video, because it was technically a little bit easier than some of the other ones. And you just want to kind of set that suture in a good spot so that you can tie it down. You can see how it cinches it right down, right into that corner. Absolutely nice and firmly adherent to the labral remnant just behind it. So this is definitely time-lapse photography. It doesn't go quite this quick. We have Andrea to thank for kind of trimming it up for us.
I think maybe I can take out a little bit of this part there.
Nah, it's okay. I think it's okay. I think it's okay. We're just getting impatient, I think. But that's basically the gist of it, to get it fixed in the very, very back. So we're looking upside down towards the back. Now you can see from front to back, you can see the labrum is nice and fixed. Each green suture represents a fixation point. We're compressing it against nice bleeding bone, which is prepared on the acetabulum. This is the best blood in the body. This is where we harvest stem cells. This is where we do bone graft for a non-union. And so this should incorporate very well. When you put the ball back into the cup, you can see an excellent seal on every aspect of the labral reconstruction of the femoral head. So again, to go back with our labral preservation ideas, we want to provide the seal to keep joint fluid in, seal to protect it with stability, and also that shear force. So that's the normal view that you're used to, right up and down, and so that came out nicely. And so we'll see how she does, but I think that gives her an opportunity, whereas the repair she had before, I think, would probably fail. So this is the other thing that we've been doing a lot. So we actually have 49 patients, which is amazing. So we have some patients that you get in here, and if you think about it, we're doing a labral reconstruction for more advanced cases. So these are the ones that are really badly damaged. This is a situation where we've burred back the labrum, but now we have a hole in the cartilage. And so you can see where we're going to do a microfracture procedure. Now the philosophy is, if we do a microfracture procedure here, we poke those holes in the bone. Remember, that's the way we do it. You need a blood clot. Blood clot needs to form. Blood clot then forms fibrocartilage. It differentiates into that. And so what you have in the situation now is, if you make all those holes, you create that blood, what's to stop that blood from just eluting out of the joint? And so then maybe you'll get this little wispy fibrocartilage. You won't get this big, thick, meaty fill. So what we do then is we put a graft in there. And you can see now all the bleeding that occurred when we did the microfracture stays put. The results from this have been amazing, at least in the short term. I mean, we're looking at a 30-point improvement in our Harris Hip score, huge improvement in level of satisfaction and lower extremity functional score. So this is somebody that you'd say, well, we're kind of pushing our limits here, but at least in the short term, the results have been fantastic. When you look at our database, we're now up to 851 patients. We've probably done about 1,000 hip scopes total, but in the database, which started in July of 2009, we're up to 851. This is since July of 2009. Our last meeting, we're at 500. So we're on average now, I think we're on a pace to do about 450 per year. When you look at our ratios, more women than men, 2/3 to 1/3. Right side more involved than the left. Don't know if that's sport related or what it is, but that's just the way it goes. 6-month follow-up. The one limitation to our database now is we're very good at capturing the preoperative data. And so we don't miss a beat. Every preoperative patient, right before you go to surgery, I need to have your pre-op forms for how bad your pain is. That's the key for a database. Because if you miss that, then it becomes retrospective and it's garbage. Okay? The post-operative, you can always gather. If you have let's say we want to review the Gonzas. Well, Tara's going to help us. We're going to go out, phone calls, mailing, everything. We're going to get that cohort. We're going to get that follow-up as of tomorrow. And so we only have 543 that have come to the clinic with more than 6-month follow-up. I take that as a good thing, but we still are kind of in that lag phase where we have some more coming in soon. But on average, a 30-point improvement in Harris Hip score, VAS score 5 to 2, so 2 is a very good score, 1 is 0 pain. Lower extremity functional score, 25-point improvement, level of satisfaction overall is a 9. These are very good results, something I'm very happy with. Word about the Harris Hip score, this is what you have to remember. The Harris Hip score is all based on the first question. How much pain do you have? None, or you ignore it, gets you 100. Slight, occasional, no compromise at all. That's a pretty good result. You're down to an 87. Mild. Uh-oh. I know how to fix that. I think I just have to go back, though. Oh, good. Perfect.